So I'm very, very excited to be at my first CAIRIBU meeting and to tell you a little bit about some of the research we've been doing over almost the last decade in my lab. So the interests in our lab are, of course, urogenital dysfunction. I've primarily done a lot of work in sexual dysfunction and started to translate some of our knowledge in that area into bladder, urethral, and pelvic floor dysfunctions as well. We're interested in both male and female, although a lot of the first part of the talk will be more male-focused. And we're interested in different models. We've looked at aging, we've looked at the impact of cardiovascular diseases and diabetes. We've also assessed some bioenergetics and metabolic dysfunction related to bladder dysfunction. And what we'll talk about today is a lot of these side effects of cancer treatments that are benign disorders that are of interest. So this will be the one and only cancer slide I'm going to show you. So what are the most common cancers in men and women? What you'll notice is quite a few of them occur in the pelvic region. And so for many of these diseases, there are hundreds of thousands of new patients that are diagnosed every year. And what you'll notice is the survivorship numbers go up every year. And so this is fantastic because our oncologists are doing their jobs and they're learning how to manage these patients. However, what happens with a lot of these treatments are adverse side effects that these patients still have to live with. And so what type of treatments are we talking about when it comes to prostate cancer? And you can substitute other types of cancers in here as well. A lot of patients will end up getting some form of radiotherapy. And when it comes to patients deciding on types of treatment regimens, what's really important to them, what you'll note, is the first, bladder function, preserving bladder function, and another one that's very important is preserving sexual function. And both of these are listed higher than surviving the cancer itself. This is more important to them. So quality of life is very important to these patients after they've gotten over their cancer. So we'll talk a little bit about animal models for assessing this. And this was a quote I found that was very applicable to animal models for research, although this is a quote of a statistician, and he was talking about statistical models, that most models are all wrong, but some are also useful. And I think that's what we have to keep in mind when we're thinking about the types of animal models we want to use when we're looking at disease. And so when I first started actually as a postdoc, was when I first had interactions with Dr. Bridget Coons, who is a radiation oncologist. She was still at Duke University at the time, and she was one of the first to do an animal model looking at the impact of prostatic radiation on sexual function. And so when I relocated to my first faculty position at East Carolina University, I connected with her and we started some collaborations, and that really got me started into the radiation field. And so her model was very clinically relevant. She did CT scans to map the prostate in each of these individual rats and then delivered an appropriate dose of radiation. Following radiation, for the entirety of this presentation, when we're referring to sexual function, we are doing nerve-mediated anesthetized direct measurements of sexual function. So in the case of the rat, in the male, we're stimulating the cavernous nerve and assessing intracavernous pressure within the crus of the penis, and this is always normalized to the mean arterial pressure of the animal. And so what Dr. Coons found was she looked at different doses and the timing, and that with both time and dose, there was an increase in the severity of erectile dysfunction. With radiation, this is a very slow developing disease, so it takes time, and you often don't see dysfunction initially, but then patients will come back years later with severe erectile dysfunction. And so this animal model nicely recapitulates that and shows that by 9 weeks there is significant erectile dysfunction. And so what do we think is causing this erectile dysfunction in these patients and in our animal model? Well, if you note in this image here, the the hypogastric plexus in the human or the major pelvic ganglia in the rat lies on the posterior lateral surface of the prostate. And so frequently, it will receive dose in addition to if it's in the area of where the tumor is. And so this is one of the things we want to assess to see how it's contributing to sexual dysfunction. And so what frequently happens is this neuronal injury called Wallerian degeneration that can occur in these pelvic nerves. And so we have an insult that could be from radiation. We see a similar degeneration that happens with prostatectomy if there's a nerve injury and the nerve starts to degenerate. You have Schwann cells that are being activated, macrophages that are recruiting to try to clear the debris, release growth factors to reconnect these nerves. And if this reconnection doesn't happen, then that's when we end up with end organ fibrosis and dysfunction of these pelvic organs. So we had a medical student in the lab, Shelby Powers, who decided to do a master's, and she looked at the neuronal and vascular injury post-radiation in this model that Dr. Kuhns had developed. So these animals were irradiated at Duke and then sent to ECU, and we looked at them 2 and 10 weeks post-radiation. And so we took these major pelvic ganglia, we excised them, and we dissociated the neurons, and then we cultured them at this 2 and 10 week post-radiation time point to see what their survival was like by assessing apoptosis with tunnel staining. We looked at outgrowth, and we also looked at the different neuronal populations, the nitrogic and the sympathetic, which are both important for erectile function. And what we saw was this temporal increase in apoptosis that was low at 2 weeks and was even higher at 10 weeks post-radiation in these dissociated ganglia. When we looked at neurite branching, we saw that it was decreased more significantly at the 10-week time point. So this is indicative of a less complex neuronal structure, and probably we're assuming less end organ connecting. We also saw a decrease in neurite length at both time points, or at the later time point. There seemed to be an increase at 2 weeks, and this could be that initial phase of the inflammation and everything's happening early in injury, where those neurons are trying to grow and reconnect. And by 10 weeks, a lot of those transcription factors and things like that are downregulated. We looked at some different markers of nerve expression, and what we saw when we looked at gene expression in the MPGs of these animals, that GFAP, which is something to indicate that the Schwann cells are differentiated and activated and going in and cleaning up all the debris, is upregulated at both of these time points. The other thing of note was this growth-associated protein 43, which is known to be important for neuronal growth cones and axon regeneration. It's down at 10 weeks, so it could be that there's not enough signaling in place to make those connections back to the penile tissue. When we looked at those nitrogic and NOS-positive neurons, both the gene expression at 10 weeks was lower, as well as the overall number of positive neurons. And similarly, when we looked at the sympathetic neurons that were stained with tyrosine hydroxylase, we saw a decrease in both the gene expression and the overall number of neurons at 10 weeks. So next we did our nerve-stimulated intracavernosal pressure measurement to assess erectile function. And we were quite surprised that we did not see the same decrease in erectile function that Dr. Kuhns had previously seen in these animals. And so, for whatever reason, because animals are not perfect models, we didn't see any change in erectile function, but it was remarkable that we did still see all of these changes in the different nerve compartments. When we looked at penile vasoconstriction, and this was work done by Michael Odom when he was in the lab, we did see very minor decrease in contraction, but nothing that would indicate that there's a big smooth muscle dysfunction here. So one of the reasons we think that erectile function didn't change was because in our case here, we just had a decrease in both the nitrogic and the sympathetic components, so we didn't have that imbalance that we often see where there's an increase in sympathetic input to the penis causing an overly constricted state. And so the other thing, we only used a 22 gray dose, and previous studies have used 25 and seen significant erectile dysfunction, so it could be that we didn't use enough dose or we needed to wait a longer period of time. So we wanted to know whether or not it was that this radiation insult to the ganglia, is it primarily acting on the nerves, or is it the glial cells, the Schwann cells that are supporting the nerves, that are causing more of the dysfunction? And so to do this, we had a medical student in the lab, Josh Randolph, who dissociated the neurons and compared the dissociated culture after they were irradiated ex vivo to a whole MPG with all of the, it's not dissociated, with all of the cells intact. And then we looked at growth 72 hours post radiation. And so what we saw in our dissociated neurons, similar to what we saw previously, length was decreased, so this was all ex vivo irradiated. And when we looked at the whole culture, we saw the opposite effect. And so post-radiation, where we thought we'd have this decrease in length, we actually had an increase in length, which indicates that maybe a lot of these supporting cells are important and playing a role in helping with that nerve regeneration. And so these Schwann cells, these glial support-like cells within the pelvic ganglia, in an injury, they will change, and so they'll become activated, they'll express more GFAP, and that's when they switch to this, instead of a myelinating type of cell, they're like a macrophage that's going to clean up a lot of the debris and provide growth factors to increase nerve regeneration. And so we looked at the Schwann cell markers in these whole ex vivo irradiated MPGs and saw that overall there was an increase in gene expression of the general Schwann cell marker SOX10. There was an increase in the myelinated Schwann cells, and in this case there was no change in GFAP. So we were able to dissociate and culture these Schwann cells from adult MPGs from the rats. And here you can see they're stained with both S100 and GFAP to indicate that these are Schwann cells. When we looked at how radiation changes some of these markers in the Schwann cells, these are all changes from just a control baseline. We see a huge increase in that GAP43, which is that marker for axonal regeneration, an increase in GFAP like we expected, and an increase in SOX2. So then our next step was to take these neurons that we can dissociate, as well as these Schwann cells, and do a co-culture and cross between them. And so we wanted to just initially see if this was going to change the amount of growth that the neurites were capable of doing. And so sure enough, when we just took regular control neurons and grew them on top of the control dissociated Schwann cells, we did see a significant increase in the amount of neurite length over a 72-hour period in these neurons. So our next step was to irradiate these neurons and Schwann cells individually and then co-culture them under these different conditions. So we have our controls that are both unirradiated for the Schwann cells and the neurons, and then we have control Schwann cells with irradiated neurons and vice versa, and then finally both populations of Schwann cells and neurons that were irradiated together. And so what we found, if we look at length, in all cases, independent of which of the cell types got radiation, we saw a big increase in length because of the presence of these Schwann cells that are providing different types of growth factors and cytokines to increase length. When we looked at apoptosis of the neurons specifically, we saw that the irradiated MPGs had an increase in apoptosis independent of the type of Schwann cells they were grown with, but it was much more severe when the Schwann cells were also irradiated. So we were hoping to get, we got a little bit of a rescue there with the control Schwann cells in place with the irradiated neurons. And then finally, in both cases, when we looked at the nitrogen neurons, so these are the nNOS positive neurons that are going to initiate those erectile responses, when they were cultured in the presence of irradiated Schwann cells or control Schwann cells, they were increased. And then when the irradiated neurons were cultured with them, they were decreased. And so that was independent of the presence of the Schwann cells. And then finally, there was not much change in the sympathetic neurons that were positively stained with tyrosine hydroxylase. And so what this showed us was that pelvic neurons and their supporting cells are undergoing apoptosis and different changes caused by the radiation. And so we've got funding from the DoD to further pursue this so that we can understand what's happening to the Schwann cells and how they're changing and how they can support the neuron growth in the presence of radiation. And really for radiation-induced ED, we need these therapies that are going to prevent both the neuronal and the vascular damage following radiation. And so to switch gears and talk a little bit about female sexual function, we've also been able to establish a female model of radiation-induced sexual dysfunction. And so what's really important when you look at the numbers for these gynecological cancers and their survivors, there are over 19 million survivors just of these specific cancers alive currently, and radiation is often most indicated in these cases. And so what are the type of side effects that these women can suffer from? Things like vaginal dryness, fibrosis, atrophy, and decreased arousal are very common side effects, and these will lead to sexual dysfunction and chronic pelvic pain. And then from the bladder side of things, it can also be impacted by increased urination, urgency, urinary leakage, so incontinence and cystitis in these survivors. And so we took the same approach with the female rat. This time we used a single dose of 20 gray. We attempted both a 15 and a 25 gray dose. And with 25 gray, we got too much damage, and so we dialed it back down to 20. So this is deemed to be a dose that the normal tissue surrounding the tumor would see. And so we looked at them at 4 and 9 weeks post-radiation, and we did similar parameters where we assessed nerve-mediated changes in vaginal blood flow, as well as vasoreactivity of the vagina, the bladder, and the urethras. And so in this case, we stimulate the pelvic nerve just like we did in the male, and we normalize this to the mean arterial pressure. However, we're using a laser Doppler probe that is placed intravaginally to measure changes in vaginal blood flow. And so what we saw when we looked at the maximal change in blood flow normalized to blood pressure was we really didn't see a change between the animals. What we also assessed was this total blood flow, which we consider to be the area under the curve. And so this is really more indicative of the overall sexual response. So the ability for the blood flow to increase and then stay increased over that time period that the nerve is being stimulated. And so we did see at 4 weeks a decrease in vaginal blood flow, or this overall response post-radiation. However, in the females, this recovered by 9 weeks. So we also looked at the vaginal epithelium, and so this is something that is very important for patients to be able to recover post-radiation, because this is where a lot of the vaginal dryness and atrophy and pain comes into play. And so in our animal model, we saw at 4 weeks, and even more significantly at 9 weeks, that there was a thinning of this vaginal epithelium. We looked at vaginal contraction in these animals and saw that At 9 weeks, we had this persistent increase in adrenergic contraction, which could be indicative of excess tone on the vagina. This could cause problems for intercourse, leading to, again, sexual pain and things like that. We also looked at bladder function in these animals. And what we saw was overall there was no change in the fibrosis of the bladders at these time points that we assessed. And we didn't really see any change in carbachol-mediated contractile responses. However, when we stimulated with electrical field stimulation to release those cholinergic neurotransmitters and cause contraction, we saw a decrease at both time points. Now we also looked at the urethral sphincters, and so we were calling these internal and external urethral sphincters. This is an example of a urethra cut longitudinally, and in the rat, it's very nice because you can see that EUS very clearly where the skeletal muscle is. It's kind of a little bit of an elevated bump just below the bladder neck. And so here it's stained with, the green is staining the myosin-heavy chain to indicate skeletal muscle, and the red is smooth muscle actin, indicating smooth muscle. And so we took these two sections and again put them in the tissue baths to look at contractility. And when we looked at both the smooth muscle and skeletal muscle content, we didn't see a change in skeletal muscle within the external urethral sphincter, but we did see a significant decrease in smooth muscle in that external urethral sphincter at both 4 and 9 weeks post-radiation. We also looked at contraction to high potassium and to caffeine. So caffeine is going to activate the ryanodine receptors to cause calcium to be released. This is something that is going to be to cause a greater contraction in the skeletal muscle versus the smooth muscle. So as you can see, this also helped us confirm that we had skeletal muscle present in our external urethral sphincter compared to the internal urethral sphincter. But in both, in the EUS with both the high potassium solution and the caffeine solution, we did see that increase in contractility at the 9-week post-radiation time point. With the, when we also looked at electrical field stimulated contraction in these urethras, we saw an increase at 4 weeks for the internal urethral sphincter that then went back down at 9 weeks, and then we saw a gradual increase in the external urethral sphincter. Finally, in these animals, we also wanted to see if there were inflammatory markers that were elevated, because we believe that inflammation is driving a lot of these changes we're seeing in smooth muscle and skeletal function. And so we looked at NIDDK oxidase 2 and 4, as well as TNF-alpha and interleukin-6. And what we found was there was an increase at this 4-week earlier time point post-radiation that was then subdued at 9 weeks. And so what we found overall in the female was that, unlike the male, where this persistent change continued in erectile dysfunction all the way through the 9-week time point, it was only there, it was more significant at 4 weeks, and there were other more subtle contractile changes that remained in place at 9 weeks. But in terms of whether or not this is a good model, we do see a decrease in vaginal blood flow, as well as that vaginal epithelial thinning that we see clinically. That's very important to be able to assess. Additionally, we see these changes in vaginal smooth muscle contraction and bladder contraction, and some changes within the urethra as well. So we wanted to see if we could improve on this model, and one of the last things we did before leaving East Carolina was try to do this in an aged model. And so we had some female spray jelly rats that were 15 months of age. They were no longer cycling, so we considered them to be postmenopausal and much more characteristic of the patients that we would see clinically having this type of radiation therapy. So we repeated our radiation, looked at 4 and 9 weeks, and measured vaginal blood flow and contractility. And unfortunately, in our aged animals, they had much lower levels of vaginal blood flow. So we've got our young animals from the data we saw previously, and when we compare it to the old were already very, very diminished prior to radiation. So radiation really didn't have much more of an impact that we could see in blood flow. Similarly, when we looked at that overall vaginal blood flow response and looked at area under the curve, it was lower in the young animals at 4 weeks and then came back up. In the aged animals, it was already depressed with age, so we didn't see any further decrease. And then when we looked at vaginal contractility, there was a small decrease at 4 weeks that came back at 9 weeks. So really, we're not seeing much change in smooth muscle function either at this stage. And then when we looked at bladder function in these older animals post-radiation, there wasn't really a big difference between the groups at all. Now what's of note is these bladders are much less contractile than the young animals, and so it begs to differ. This may be not an ideal animal model because there's already so much dysfunction in place due to the aging that you can't use it to add another insult to the animal and expect to see anything. So this was a lesson that maybe these younger models aren't always so bad. Another thing we'd like to do is look at ovarectomize to see if that is better to mimic the postmenopausal stage rather than aged animals. And so due to the changes in age, we couldn't see a big impact from radiation. So this is a lesson that think about your animal models and see what's the best way to do it. We're going to do vaginal histology to see what type of vaginal epithelial thinning we see in these animals with the radiation, and do some shore staining to look at the vaginal cytology as well. And then we talked about multidisciplinary teams earlier, and so this is a group that we're working on the female sexual dysfunction side of things with radiation. It's really been led by this radiation oncologist at Mount Sinai, Dr. Deborah Marshall, and we're working together with a biomaterials engineer and a chemical engineer to try to find some sort of therapy that we can help these women in mitigating these symptoms of vaginal dysfunction. So I'd like to end just by saying that these cancer survivors are perhaps free of their cancerous disease, however, they're not free of disease. So it's really important that we study these benign conditions in these cancer patients in order to give them the best quality of life. With that, these are my funding acknowledgements as well as prior lab members, and I would be happy to take any questions.